All right, let's go ahead and get started with procedure, skills, and administration. And usually when I say the word administration, that's when the doors fly open and everybody runs out. I think this is probably worth your time from a board review standpoint because there's a fair amount of information here that is dispersed among multiple topics that you probably won't have the time or interest in looking at or studying, but I've really tried to put in the important information into this talk so that you won't have to. There's no way, in my opinion, that you could take a look at the core content curriculum and look at all the details in these sections, these appendices, and decide which ones you really think are testable, which ones you aren't, and it is not worth your time to study them all. So we'll try and narrow it down for you. We'll go through some procedures, we'll go through some administrative things that we think will be testable, and hopefully each and every one of you will get an additional question or two right that you wouldn't have if we hadn't done this. Does that sound okay? You guys are a quiet group. So you did go out last night. Yeah, maybe a little bit. All right, one thing I wanted to show you as well, this is from the Model Clinical Practice of Emergency Medicine from 2011. The 2011 version, which was published, I think, in 2012, is the one they're using for the test. Other testing agencies are going to follow suit as well. But this kind of gives you a sense, too, when you look at ABEM's website, this is the breakdown of what they expect will be on your test. And the reason I list this is so you'll have it, but also so you'll take a look at the bottom, look at the appendices. Procedures and skills and administration are going to total about 11%. So this is probably worth your time. And again, hopefully, there'll be a couple things here you hadn't heard before. Maybe there'll be some clinical pearls that'll be valuable to you. Or maybe it'll be 75 minutes that you know you will never get back again. So we'll see what'll happen. All right, so the first thing, procedures, and that'll maybe be a little bit more fun, but we'll talk about this. All right, so the first thing is airway. There are always airway questions. There are some other airway comments and topics discussed in some of the other lectures, but we need to hit on a couple things procedure-wise here. So, cricothyroidotomy, it could be a trick question. Are there any absolute contraindications? Actually, no. If you have no other means to secure an airway, you need to do a surgical airway, but depending on age group, it may change the way you're going to do it. So relative contraindications, age less than 10, could lead to subglottic stenosis. Also, we know that in the very young, the cricothyroid membrane may be the strongest structure in the airway, and violating that could actually result in a collapsed airway. That's why you want to be careful with a complete surgical airway in that age group and maybe do needle cricothyroidotomy. But you still need to do it. Very important. Remember your landmarks. Worry about bleeding diatheses, and complications are listed here. Hopefully you won't run into any of those. The nice thing about this is if you need this, the number one complication, if you don't do it, is respiratory arrest and death. So you have to do it. And so if they ask you that question about absolute contraindications, be very careful about jumping into that because really there are none. All right, so transtracheal jet ventilation. This is important. And again, this is all from the core content curriculum, so it's all fair game. It's a temporizing device, so you're trying to be able to oxygenate someone and temporarily ventilate them while you can work on getting a more permanent airway. And the big issue here, the limitation in red, is hypercapnia. You're not going to be able to ventilate them very well, so it's not going to be able to be done for long. So maximum of 30 minutes, and hypercapnia is the limitation. You want a 4-to-1 expiratory to inspiratory ratio. So however you do it, whether it's a bag, whether it's a demand valve, whether you have a stopcock with tubing like I'll show you, you want to make sure that you give them 4 times the duration in expiration or exhalation than you would when you're giving them the breath. You've got to improve the amount of time you can use this by getting them to decrease the PCO2 and limit the hypercapnia that you have. Okay, you want a 2.8 to 3.0 millimeter internal diameter kink-resistant catheter. It can be 6 French also. The reason I mention this is many textbooks and in clinical practice, we're oftentimes taught you can just use an angiocath, an IV catheter. You can get into the cricothyroid membrane very easily with an IV catheter, but the minute you pull the needle out, they kink, and it's a problem. So I would be really careful doing that. I don't have any financial interest in these devices, but the ones that I like to have stocked at the places I work, I think one is called the Patel, and I think Cook either produces that or sells that. But what's nice about it, it has a curve to it. It's preloaded on a syringe, but it has a coil in it, so it's kink resistant. If you get it in, it's not going to kink on you. So anyone's device is fine, but just an angiocath isn't really going to get you there. Something that's interesting in the literature, and I got to do once a couple of years ago, was a guy with a horrible airway and facial trauma, et cetera. And this guy, there was a lot of blood in the airway. He needed a surgical airway. So I went ahead and did this first, and then you could tell that he's being ventilated well enough. I'm like, I'm going to take another look because I read about this. And once you're ventilating with transtracheal jet ventilation and you insufflate that area, you may have better visualization. Look, wow, I can put an endotracheal tube in now. Pull this out, put the tube in, we're good to go. A little hole, not a big formal cricothyroidotomy. So something to consider too. It can facilitate glottic opening. All right, this is just an image to show you what you can do with a stopcock. You need 50 psi minimum to do this. You can use a stopcock that you can turn. You can cut actually part of the tubing away that you can put your thumb over and hold it down and take it off, that type of thing. They list angiocath here. We've already talked about that it's funny. You take even a look at the image, and somehow their angiocath is able to bend without kinking. That's because they drew the picture. If they took a picture of it, it would have a sharp bend and it would be kinking. You'd have to replace it. If you like to do a lot of these and want to get really proficient, then do the angiocath, because every couple of minutes you'll have to put another one in, and by the end of the day, you'll have put in about 10 of them, and you'll be very good at this. So, all right. So additional things on airway. Confirmation of endotracheal tube placement is very important. If they ever give you the option, they want you to listen. They want a chest x-ray, but the chest x-ray is where they're going to pull you in to make a mistake. The chest x-ray is just to make sure everything else is okay and to make sure that it's not really a right mainstem bronchus intubation that you didn't identify. If you are using or you choose on the exam a chest x-ray to confirm the tube is actually in the trachea, that's way too long. If you get the chest x-ray that shows the tip of the tube beneath the carina and you didn't know that in advance, that's a clinical failure, and it will be a missed answer on the examination for sure if you go that way. Auscultation is important. Listening to the epigastric area first, because there are almost always fluid contents in the gastric area. If you listen to the lower chest first, you might transmit some of the gastric sound waves into the lower chest. I think I hear it. I think it's in. But if you go right here first and you hear it, you're like, oh, we're in the esophagus. I got to pull this out. Start here. Go to the chest. Capnometry is important. It's reliable. If the pulse is present, if you have a low flow state, you're doing CPR, it's really not that helpful, so you don't have to use it. If you're given the option of just throw everything else out and grab the laryngoscope and just take a look, visualization is the way to go. I can see the tube going between the cords. I don't care about anything else. It's where it needs to be. That is the right answer for the examination. Has anyone used esophageal detector devices? I thought you were raising your hand. You just have an itch. These are like big turkey basters. You used them, okay. Big turkey basters, you can use this instead of an end-tidal CO2 detector if you want. And it's got to have a catheter tip at the end of it, not a Luer lock, okay? And what you can do is connect it to the end of the endotracheal tube. You're not going to use the baster portion. You want to actually be able to withdraw air. And the theory is, and it works pretty well, it's been proven in the literature to work pretty well, if you can continue to withdraw air, you're probably in the trachea because the cartilaginous rings of the trachea will not collapse under negative pressure. If you're in the esophagus, there are no cartilaginous rings. It will collapse under negative pressure, and you won't get any return. It's like, oh boy, I'm probably in the esophagus. Just be careful a little bit, some false negatives, when you have low residual capacity. There's very little dead space in the airway, and that's for people who don't have a lot of extra air there. So COPD, obesity, pregnancy, you've got weight on this area, there's not a lot of extra there, you can have a false negative, and false positives don't really seem to happen. And again, chest x-ray is not a primary tool for endotracheal tube placement confirmation. All right, now I've put a bunch of citations in here. When I place a citation in this particular talk, it's because it was one of the LLSA articles that you probably will be required to know on the exam. Now, they decided the year after I took my last consort that we're not going to have to know all these articles. It would have been hundreds and hundreds and hundreds of articles that we're responsible for. And what they have said, though, is that if it is a practice-changing article, it's very important, then we may want to test you, not necessarily from an exact sentence or line from the article like they did in the first year that they were doing that, back in 2006, but they will test you on the concept. So I've picked the articles over the last 10 years and thrown them in some of the lectures, but particularly this one, that I think you need to know about and also may change your practice. So this one is about capnography, and the wave is moving toward capnography. We definitely want to use that. And this article talks about lots of different things. And you need to be thinking about the indications. It's very important. Capnometry is the little device you connect to the endotracheal tube. That's fine. But capnography is giving you a waveform. You can use it for procedural sedation, which is very helpful. If we say we do it just as well as anesthesia, then we need to do it as safely as anesthesia. They're using capnography. We need to use capnography. You know, BiPAP, what do we recommend for BiPAP? You put somebody on bilevel ventilation, and we're supposed to get an ABG 20 or 30 minutes later, right? Isn't that the recommendation? I'd say you don't need an ABG at all. Get a VBG, but you don't need either. Because if you have capnography and the PCO2 is climbing, they're failing. And you can go move to the intubation at that point or change your management. Mechanically ventilated patients. Well, if there's a problem, you'd like to make sure everything is exactly the way you expect it to be on your end-tidal CO2 waveform. You want it to be where it's at. If there's a change in it, maybe there's a change in status of the patient. Has the tube become dislodged? Is there something else going on? And the one that won't be tested on that I find is fascinating, that is very interesting, is DKA. There are only a few articles. One that I like from 2007. It's Pediatric, the Journal of Pediatrics and Children's Health. And they looked at some kids with DKA. They looked at about, I think it was 28 kids with type 1 diabetes, okay? 15 of them had DKA. 0 of the 15 had a PCO2 greater than 30, an end-tidal CO2 greater than 30. So what that tells us is we can be non-invasive. If you have a type 1 diabetic in your department, measure their end-tidal CO2. And if it's dropping, they're hyperventilating more and more and more, you're watching them go into DKA right in front of you without even needing a VBG, without even needing any blood work. And I think that's a helpful, useful thing clinically, but that portion won't be on the test. But the use of capnography will be. All right, this is a relatively new LLSA article, but an important one, again in the airway area. And this is about airway management in obese adults. This image is taken right from the article also, so you can get a sense. Use CPAP during pre-oxygenation is one thing they could test you on. You really want to oxygenate them well and improve your oxygenation time, then maybe use CPAP in advance instead of just throwing some O2 on them. Use the ramped position. What that means is you are putting a bunch under their head and their shoulders, towels, pillows, whatever you need to make sure that the external auditory canals are basically at the same level as the sternal notch. And that's a good piece of information in these patients because they're just built differently and they are difficult airways. And then use the total body weight to dose succinylcholine, not the ideal body weight. And that's important too. I always like to hear people say, well, I don't want to give too much succinylcholine. It's like, why? You're going to paralyze them too much? I mean, it's all temporary anyway, and what you don't want to do is have to redose with succinylcholine. There's an idiosyncratic response with succinylcholine that can cause bradycardia when you give a second dose. Don't know why it happens. Maybe it's vaguely related, not really sure exactly why. But you'd rather give a big old whopping dose up front and get the effect that you want, not paralyze them just a little bit. That's not what you're after. All right, and this article, also from one of the recent LLSA articles, avoiding circulatory complications during endotracheal intubation. So people get hypotensive when we remove their catecholamine surge, we give them positive pressure ventilation, we reduce venous return. All those things happen. We should grow to expect it, particularly in patients who are already hypotensive or those who are tachycardic who are compensating. They are not hypotensive yet, but they're tachycardic. We knock out all that response. It's only going to get worse. So we know that when we sedate them and when we do our rapid sequence intubation, we remove that catecholamine surge, they're going to drop, so we can do fluid boluses, we can even give small doses of phenylephrine, other things that we can do. So just be aware of this article and be aware of who they're concerned about. Even morbidly obese patients, they say, have a large vascular capacitance and they're at greater risk. Okay? All right, some more procedures. How many of you are doing regional nerve blocks? These are, okay, a few of you. These are all in the core content curriculum, and I think it's important just to be familiar with them, so we'll run through some of these, and I think clinically you may want to try these also. And the tough thing is, when you try one, and you haven't done it before, your confidence level's not that great, correct? Anybody? Yeah, you're not feeling overwhelmingly confident. And tell you, when I've started to do these, I've scripted myself a little bit. So if I found a new regional block, I mean, for instance, you're doing a plantar aspect of a foot. Who wants to stick a needle in the plantar aspect of a foot? It makes no sense. It hurts. It doesn't work well. The anesthetic seems to run out all over the place. You want to learn how to do an ankle block. But if you haven't done one before, you're expecting that you might fail, at least on the first couple. So what I recommend you say is, listen, we're going to try this so it's easier for you. We can always inject some directly if we need to. if your anatomy runs where most people's anatomy does, then this should give you some significant relief. If not, well, then we'll just go to the traditional technique. But I'm going to try and save you some pain with this. So you've already put it on them. So when you do the ankle block or the wrist block, and they're like, is it numb? It's like, no. It's like, damn, my anatomy. They always tell me that. So it's them. They've already accepted that it's not you. So it's not your failure. And then once you realize, I could have done this a little differently, you get better at it. How many of you do dental blocks? Yeah, dental blocks are great. They're a crowd pleaser. I always like to ask this question. How many milliliters of local anesthetic do you use for dental blocks? Anybody? You're 5, 1 to 3. You're better than me. 1 to 3 is usually the answer that I get, and that's what you see in most of the textbooks. I'm not an oral maxillofacial surgeon, so my awareness of the anatomy may not be that great. The way I look at it, if you put 5 to 10 cc's of bupivacaine anywhere in the head and neck area, shit will get numb. It will. Then you can also say, well, so your nerves run in a different area. You are numb over here. I'm sorry your 2 still hurts over here. But, you can get better at this. I don't think, not necessarily 10, but I agree with you. 5, absolutely. And I don't know why we use short-acting local anesthetics, even for lacerations these days. Short-acting, you get pulled away. Now you've got to re-inject them. They are pissed off. They are unhappy. Just use the long-acting stuff, and it gives them pain relief once they leave, too. All right, so let's talk about wrist blocks, and let's talk about ankle blocks. And I think they'll help you, and they could be testable also. So radial nerve block, it's really easy. If you look at the anatomical snuff box, and you feel there is actually a radial styloid just like there's an ulnar styloid. It's just not as prominent to feel. So feel the radial styloid. That is the proximal border of the anatomical snuff box. Just come slightly back proximal to that, and you can see where the needle is being inserted here. And you do an approach where you start to inject there, and you go across the top, laying anesthetic in that area. If you want to move toward the snuff box, then you can do kind of a fanning approach in that area as well across the anatomical snuff box because multiple branches go out that direction. It's subcutaneous. It's, you can put as much as 5 to 10 milliliters if you want to because you're not going into a closed compartment, and it works really well. Look what you get. You get the dorsal aspect of the radial side. You get the thumb, you get part of that hand, you get a little tiny bit of the index finger. So it's very helpful. And that nerve is located right where I mentioned, then it branches off into 2 main branches, and then you get a bunch of perforating branches right at and after the anatomical snuff box, okay? All right, so let's talk about the ulnar nerve block. This one is really easy too, and this really helps. What this gives you, it's nice, because it gives you the palmar and the dorsal surface of the ulnar side of the hand, the whole thing, including a good portion, not just the 5th digit, but also the 4th, a tiny little bit of the 3rd. So basically this whole side, like a partial glove, it's going to give you that. And it is so easy. You look at the picture, you can go straight on, and what you do is feel the flexor carpi ulnaris. Do you feel it? Somebody give me some confirmation. This is an easy one. Flexor carpi ulnaris, right here. Flexor carpi ulnaris. You got it? See, most people are holding it. If you don't want to do it on yourself, grab your partner's wrist. Somebody sitting next to you. Flexor carpi ulnaris, move it around a little bit. And if you want to go from this angle, you need to feel the ulnar artery if you can. You try and go away from it. If you can't feel it, just aspirate and make sure that you don't have bright red blood. You can gently go in about 1 centimeter. If you tap bone, gently withdraw, and you can lay your anesthetic there about 3 to 5 milliliters. The approach that I prefer, and that's the one I use, I don't know if you'll prefer it or not, but you don't have to worry about the arteries so much, is going from the side. Feel that thing. Flexor carpi ulnaris, go in from the side. You can feel it. You can get right underneath it. You go, put the tip of the needle just past it. You can grab it and feel the width of it. Go right past it. Certainly aspirate. If there's nothing there, then go ahead and lay your anesthetic there. Some people have advocated coming out to the service and then going to the volar surface here a little bit and giving a little fan because there might be some perforating branches of the nerve there. I haven't found that to be necessary. And this is very easy, and it's very successful, and it really helps. All right, the median nerve block, I won't talk about the distribution in great detail because it gives you everything else that the ulnar and the radial didn't. And so this is very, very easy to do. So if you take a look at the median nerve block, you need to find the flexor carpi radialis over here. And if you have a palmaris longus, I think this is a remnant from the cat family, there's a space right in between them. That's where you want to go, right at the crease of the wrist, basically, or maybe 1 finger breadth proximal, okay? That's where you want to go. If your patient doesn't have a palmaris longus, you just go to the ulnar side of the flexor carpi radialis, the ulnar side, okay? And you're going to try and pop through the fascia. Most people who've written about this say that's kind of a myth. You need to get through there, but you're not going to feel the pop all the time. So gently go in at a slight angle. When you feel bone, gently withdraw and lay your anesthetic right there, about 3 to 5 milliliters again. That's all you need to do, and you will get this distribution. So this image shows you going straight in, and you can do that. To improve your accuracy with actually getting the anesthetic delivered to the nerve you want, like I said, I suggest angling a little bit toward the hand, and it seems to work a little bit better, okay? All right, now the ankle blocks. The two biggies are really the superficial peroneal or peroneal nerve and the posterior tibial nerve. The posterior tibial nerve is interesting. I'll go back here a little bit and we'll look at this anatomy again. If you take a look at this, the posterior tibial is going to give you most of the plantar aspect of the foot. It's going to give you almost all of that. It gives you the medial and the lateral plantar nerve. Those are branches from the tibial nerve, and the calcaneal nerve is a branch from the tibial nerve. So if you just do the tibial nerve block, you've got most of the plantar aspect, okay? And then we talk about the other component on the anterior surface, superficial peroneal or peroneal nerve. Look, in the purple on the dorsal aspect, you get most of the dorsal surface. So how do we do them? They are really easy to do. And most of the time, even if you don't feel proficient yet, you're going to get at least some response and get some partial anesthetic benefit. And as you get better and you put more anesthetic in, these are not closed spaces either. You can put a fair amount in, you're going to do pretty well. So let's talk about the posterior tibial first. Palpate the pulse, okay, of the posterior tibial area, posterior tibial artery. So it's your medial malleolus. And you're going to come up it's about a finger's breadth from the bottom of the malleolus is where you're going to be. You're going to come from the back, and you're going to gently insert the needle. You're going to be aspirating, no blood. You tap the back portion of the tibia, you withdraw, and you go ahead and put your anesthetic right there. It will work. You're just up from the inferior aspect of the medial malleolus, okay, just proximal to that. All right, and the superficial peroneal nerve, it's interesting. You want to take the anterior ridge of the tibia on the front. You can feel it on anybody. And that's where you insert the needle. And then go laterally, and you want to infiltrate a lot of anesthetic. And the key is this needs to be subcutaneous. So they recommend when you enter, do a little subcutaneous wheel to make sure that you are sub-Q. These nerves are superficial. You go too deep, you miss it all. You've got to be superficial. And then you just go laterally toward the lateral malleolus. That's all you need to do. And it works very, very well. And you can get most of the foot with those two blocks here. Two good examples right here of how to do that, where you're going to insert the needle. All right, paracentesis. Here are the classic contraindications listed here. Acute abdomen, of course. You're not going to go into somebody's abdomen that has acute abdominal findings. Maybe a platelet count less than 20,000. That's what used to be stated. An INR greater than 2.0. Those are relative contraindications. Pregnancy, keep the needle away from the baby. Distended bladder, distended bowel, cellulitis, don't go through cellulitic skin, and adhesions. This article listed from New England Journal is an LLSA article, and what they looked at were people that had coagulopathies, either iatrogenic because they were on meds or they were thrombocytopenic. And they did paracentesis on these people. Do you know what percentage actually developed a complication from the procedure? I think it was less than 0.2%. It was a very small number. Very small number. So that is no longer an absolute contraindication. You need to consider it, but since it's an LLSA article, I could see that being a test question. So the patient's platelet count is 50,000, and they've got this, all the ascites. Are you still going to do the tap? Yes, I am. I'm going to do it because there's not going to be much risk. All right, this is ugly. Many of you may not recognize this. After day 4, not only will you recognize this, you'll be on a first-name basis with this, sitting in this room for this long. But you may think it's silly. Why would we get tested on esoteric stuff like this? Well, I have it on good authority that you would be surprised what esoteric stuff that you get tested on. Know this piece of information. I promise you need to know it. So 48 to 72 hours within onset of symptoms, they want you to IND this, remove the clot if it's thrombosed. And this is important. They want local anesthetic infiltrated. Many of us may not do that because it's like 2 sticks. You can offer it to the patient if they don't want it because you can just end this by opening it and sizing it. They may not want it. But if for the test, you absolutely use some local anesthetic. And there are many ways to incise this. You can do a linear incision. You can do a stab incision. And we do them many ways that are successful. I don't think this is as clinically relevant, but for the examination, it's an elliptical incision. You remove the tissue and the clot. A little football has to come out, and you leave it open. You can put a little packing in if you want. It's not really all that important. It'll stop bleeding. It won't be a big deal. They also state greater than 72 hours, if it's been there that long, then maybe conservative medical therapy, which is like sit spas and steroid creams, that type of thing. You know what? I don't think there's anything wrong if you see a clot and it's tender that you go ahead and express it. But I think what they would test you on is more likely what type of incision you would make. All right, nail trephination. We were taught many years ago, and probably many people in this room, that if you see a subungual hematoma of greater than 50% or greater, you've got to then take off the nail and explore the nail bed and repair it. Were you taught that? Anyone? It's crazy. So you have to explain to the patient, I'm going to remove the nail that appears to be intact, like the hood of a car. And then when I'm all done looking at this, and when I try and suture this, and you watch me suture it, and I can't get the sutures in anyway because this chromic or Vicryl, whatever I'm using, it doesn't want to go in here very well, and the needle doesn't want to go through this subungual tissue very well, I'm struggling with it, and now I'm going to reattach the nail that I just took off as like a hood of a car. It makes no sense. It takes a lot of time. And the data is very clear. Trephination gives you just as good a cosmetic result and outcome. And it's just as effective. So you don't have to do a nail bed exploration anymore. You can use either a needle or cautery. How many of you use electrocautery to just poke the hole in there and drain this? You guys are so much better than me. I don't think I have an attention span to do that, so I use a needle. I'm worried that I have this very hot poker, and I'm burning through this, and someone distracts me, and I'm going right into the nail bed, and they'll be hurt. So I use a needle, use an 18-gauge needle, and I whittle it back and forth. The criticism of that technique is when you do that, the blood kind of comes out, and then it clots. If you use too small of a needle, it clots very quickly. A couple things that I've done that help me, and so you don't have to put 15 little holes all over the nail, you don't want to do that, is tip the bevel into the hole you've created, and that'll help facilitate some of the blood to come out. And I don't know why I tried to do this at one point, but this absolutely works, is I take about 3 or 4 alcohol preps in with me, and I undo them. And then I put the tip, the edge of the alcohol prep, in the bevel of the needle in the hole, and it absorbs the blood and it sucks it out, and the alcohol, I assume, will not let it clot in that hole. When it fills up, you take another one and set it down there, and it helps facilitate the blood coming out. It works great. So trephination is really, really the way to go, and you don't have to explore a nail bed. And whether you use electrocautery or whether you use a needle, it doesn't matter, but I thought I'd give you that quick pearl. Wound care, another LLSA article. This was done with kids, but it could be extrapolated to adults. On the face, if you use absorbable plain gut, not chromic, plain gut, they do not have to have the sutures removed later, and the cosmetic result is the same as if you use nylon or some other, what we appear to be less inflammatory type of suture material. We used to think, well, you know, something else that is organic in nature, it's going to cause an inflammatory response. The inflammation is going to cause, you know, changes in the skin. It's going to affect healing, and it's going to cause more scarring. That is not true. So you can tell parents they don't have to have these removed. They should have a wound check, but they don't have to have it removed. I believe this will be tested for sure. It's not this LLSA article, although it was published in 2004, it was in a more recent LLSA exam, okay? Remember, they don't necessarily take them from that year. They take them based on who submits them and if they're interesting and pertinent to emergency medicine. All right, we'll bust through this quickly, but I want to hit some of the most important things in the new Heart Association guidelines since you've taken the exam last. So 2010 was when this was published. They've changed a fair amount of things. And you're beyond the Heart Association's guidelines. You practice medicine way beyond this, but they could easily test you on these. We're not going through ATLS in this discussion. You can review some of those concepts at your leisure. But let's talk about this. They've gone to a simpler approach. Look, listen, and feel is gone, and now it's just push hard and push fast. They've just made it easy, okay? And they, of course, want you to go to compressions as opposed to ventilations first. You can look at this 2 ways. Either we've underestimated the value of compressions and overestimated the value of ventilation, or what we really need to know, and we mentioned this yesterday a little bit, is that you really need electricity in those who have a shockable rhythm. And you've got to be doing something that looks official while you're waiting for the defibrillator, so you do CPR. My feeling is, if we can do CPR and it's just as effective without ventilations, then that pretty much confirms for me that CPR just doesn't work. It just doesn't work. But that's not what they're saying at this point. Compression's first. And this is the kind of algorithm they're developing. They're trying to make it more visual for you as opposed to a flow chart, and they're doing it in both ways. Well, here are the changes with BLS. Look, listen, and feel is gone, as I mentioned, and also the order is changed. It's compression, airway, breathing, not ABCs. The ABCs are gone. That is a testable item, I think particularly for the qualifying exam, but they could get it on the concert also. They want the compression rate for adults at least 100. They want it greater than 100, and compression depth at least 2 inches. So harder, faster, like they said. Okay? And there are a couple things here listed. The ratio is going to be 30 to 2. If you have 2 healthcare providers, you can go 15 to 2 if you want to. And they want a breath every 6 to 8 seconds, and they want it asynchronous to the compressions. They don't want you working together. They want the breaths delivered, and they want the compressions delivered, and they want you to do your own work. All right, so let's look at ACLS. Here is the new type of flow chart, the circular algorithm. And they published both, the old flowchart type and the circular algorithm. Maybe you like this best. But some of the changes, they want 2 minutes of CPR in between every intervention before you deliver another shock or do something else. Something else that is interesting is if you notice with VFib and VTAC, what used to be listed here was amiodarone and lidocaine. You could use either. Now they have dropped lidocaine off here. It's still in the manual, and you can use it. But amiodarone is the only ventricular antidysrhythmic listed in the algorithm flowchart or the circular algorithm. Okay? This is the exact same information. I want to show it to you. This is the circular. This is the traditional one. It has all the same information in it, but you may appreciate one approach or the other. It doesn't really matter. Bradycardia algorithm, the only important things here are, the first thing is, and this is testable, they don't want you to treat patients if they are not symptomatic. If they're asymptomatic, they want you to observe them and monitor them. If they're symptomatic, they want to treat it, of course, go with atropine. Remember, you might have this phenomenon with your high-degree blocks, second-degree type 2 in particular, that if you give a dose of atropine and it gets worse, then it's a very diseased AV node, and you shouldn't force more impulses through with atropine, so atropine can make it worse. Stop and go to something else. That can happen with a high-degree block. And the other change is right here. Before, we went with atropine, then they said go with transcutaneous pacing. They're moving away from it a little bit. They've said now you can either go to transcutaneous pacing or use something that's a chronotropic agent. So you can use either dopamine or you can use epinephrine. So epinephrine is going to be 2 to 10 mics per minute. The dopamine, 2 to 10 mics, but per kilo per minute. You can use either one of those in place of transcutaneous pacing, and I think it works better anyway. All right, tachycardia algorithm. This is practice changing with the way they've looked at this, and the big change here is the wide QRS complex tachycardia of unknown etiology. So here is the take-home message here. They say go ahead and use adenosine if it is monomorphic and it's regular. And they know, and Amma will talk about this a little bit too, I'm sure, that you have to be a little careful because adenosine will abate some episodes of VTAC. So don't just say, oh, well, it must have been SVT, so now I will send you home. Depending on your risk factors for VTAC, if they're 20 years old, no history or otherwise, okay, maybe it was just SVT. Maybe you can send them home. They're 60 years old, they have 3 stents, and they've had a previous cardiac arrest. That wasn't an SVT. Don't send them home, still admit them. So go with the adenosine first. And they're saying, some people have said, it's addressed in the manual, well, wait a minute, if it's a wide complex tachycardia and it's monomorphic, what about Wolff-Parkinson-White? Don't you get a wide complex tachycardia that way? You can get a wide complex tachycardia. So you wouldn't want to block the AV node because we've all been taught that when you block the AV node, you send all those impulses that were going to the AV node, then down the accessory pathway, and we kill people that way, right? Anyone ever hear that before? Okay, yeah, we were taught that. It's wrong. It made good sense. It made good sense, as much good sense as bicarb in cardiac arrest. Well, the body makes bicarb. That's how it treats acidosis, so we should just give it. When you study it, it doesn't work. Here is the issue. Every SVT, whether it's based on Wolff-Parkinson-White or in that context or not, has a component of AV nodal reentry, even with Wolff-Parkinson-White. So if you block the AV node, whether it's beta blockers, adenosine, calcium channel blockers, it doesn't matter. If you can stop that AV nodal reentrant process that's spinning off some of its beats into the accessory pathway, you're going to make it better. Obviously, if it makes it worse, don't give more. but it should abate the whole thing. Here's the difference that they want you to remember that I think is very testable. If it's not monomorphic and it's not regular, then could this be atrial fibrillation superimposed on Wolff-Parkinson-White? In atrial fibrillation, if we block the AV node, what's going to happen there? All the impulses that are generated from AFib are going to go right to the accessory pathway because it's not predominantly using the AV node the way that other tachycardias are. And if you block the AV node with atrial fibrillation and Wolff-Parkinson-White, you will send them into a rate of 400, 500, 600, and you can cause death. Matter of fact, the safest way to go, in my opinion, if it is Wolff-Parkinson-White and it is atrial fib, cardioversion. Electrical cardioversion is the safest, quickest, and best way to go. If you're given that option, that's where I would go. If they're stable, you could try some other things, procainamide and those type of things. You can do that. You should never be faulted for cardioverting Wolff-Parkinson-White with atrial fibrillation. So that's a big change. All right, this is a summary of the things that I didn't really list, but are also in the new algorithms. They want quantitative waveform capnography, not just to confirm the tube placement, but crazy. No data to really support this, but to assess the effectiveness of your CPR. It's a low flow state. It's probably not going to work, but they say they want that done. Also, atropine is no longer recommended as a routine treatment for asystole and PEA. It's just epinephrine. Unless you have a reason to give atropine, you don't give it. It's not a routine drug anymore. We talked about the chronotropic agents for bradycardia. Adenosine we just talked about, and they're really into post-cardiac arrest care. Return of spontaneous circulation using therapeutic hypothermia. I know there's some controversy there. If it's on the test and they give you the option of using it, and it's within the narrow confines, primary ventricular fibrillation arrest, and they have return of spontaneous circulation, but they don't wake up, you should employ therapeutic hypothermia for the test. They may not even go there because there's controversy, but if they do, they want you to use it. All right, let's talk about PALS just a little bit. Same type of changes. And I don't want to mention much here in the pulseless arrest algorithm, but it's the same thing. Lidocaine's gone. Amiodarone is here. For the kids, 5 mg per kilo, okay? That's going to be your loading dose. For the adults in cardiac arrest, it's 300 milligrams IV push. If that doesn't work, you go to 150. And if you do convert them, 1 milligram per minute over 6 hours. If it's just VTAC in adults and they haven't arrested and you treat them with amiodarone, it's 150 over 10 minutes, then the 1 milligram per minute over 6 hours, okay? All right, bradycardia algorithm, really not a lot new here, but wanted you to be aware of it. And the tachycardia algorithm has some new changes, and it's interesting. So they're looking at cutoff points with infants, 220 per minute above or below, and children, 180 above or below. So if it's below those numbers, if it's an infant and the heart rate is less than 220, or if it's a child and it's less than 180, they're saying this is not a primary dysrhythmia. This is compensatory. So let's take sepsis or pain or fever, and the heart rate goes up. Should you be treating them with an antidysrhythmic to slow the heart rate down? If they have volume loss or sepsis, that makes no sense. It'll slow it down, but they're compensating, and you need to let that compensatory mechanism take place. If the heart rate is above 220 in infants, if it's above 180 in children, well, then they're saying it's more likely a primary dysrhythmia and treat the dysrhythmia. And you know how to go down that part of the algorithm. But that's where they would ask the question, I think, which direction do you go? I'd love to see a question that the kid is septic, they're tachycardic. What do you want? Do you want fluids or do you want adenosine? I want fluids. That's where you want to go. All right, newborn resuscitation algorithm, just a couple things here which are important. They're saying if you've got a heart rate of 100, just really aggressively stimulate them and try and ventilate them with positive pressure ventilation. That's not working, and the heart rate drops below 60. And so for PALS, the heart rate drops below 60, you start compressions, and in newborn resuscitation, once it's dropped below 60, just intubate them and also make sure that you continue the compressions. That's the big deal there. This is an overall summary for you to review later. We don't need to go over these concepts again. All right, another LLSA article calling into question the value of the Broslow tape. Anyone using Broslow in your department? You know, I met Jim Broslow a few years ago. It was actually at one of our courses. I was at our Arlington course, and I had to tell him, we were on the phone. We've become great friends now. I was on the phone with him for an hour and a half while he was explaining to me the history of all this and everything. And I had to tell him at the end of this, I said, Jim, I really have to tell you this. You're way too modest with what you did to help emergency medicine and pediatric patients back in 1984 when you started this. But I tell you, your modesty has also created some misconceptions out there. Jim, I thought you were dead. I did. I thought he was long gone. No, he's alive and doing well, living in North Carolina in the Charlotte area. He's great. And he's doing great things with this and actually coming up with an electronic version of this. But anyway, this article says, you know what, maybe the way kids are built these days, this doesn't work as well as it used to. When this was developed in 1984, our kids were more, rectangular shaped. Now they're more cuboid. So does it make a difference? Do we need to develop something that's more like something to measure your shoe size that comes out this way and this way? You get width and, well, let's take a look at the data. They looked at 372 patients, about 46 months, and they were obese, all of them. The docs were better than Broslow at identifying the actual weight, but both were horrible. Both were horrible. Well, I asked Jim about this, and he said it doesn't matter. I've looked at the data. What we're trying to estimate is ideal body weight, and it works. It doesn't matter how big they are. The length still correlates with the ideal body weight, and in most circumstances, that's what we want to calculate the drug based on, the drug dose, and then we want to calculate the instruments or the equipment size based on ideal body weight. And I believe that. That makes sense. All right, joint reductions. Let's talk about a few of these, okay? Posterior elbow dislocation. What I won't say for every one of these, with the exception of shoulders, everything really should have appropriate procedural sedation for this, okay? A couple things you can do. I mean, with an elbow, you can actually have the person laying supine, have one person hold the proximal humerus, and you can slightly flex it and put traction this way, and it might work. Not as effective, but it can work. The image shows somebody laying prone and laying the arm over the bed, okay? And what you can do is put some traction in, and someone else can do it, or you can do it yourself and use your thumb to facilitate the olecranon over the trochlea. And that works. One that works great, I actually learned at this course about 4 or 5 years ago. There was a lady that was like this tall. She goes, I work in Aspen. I do them all the time. I don't have a lot of strength. Can I show you the way that I do this? It is so easy. And I've adopted this. It works great. Do you guys want to see it? Then I need a volunteer because I got to show it on somebody. You don't have to dislocate your elbow, but I want you to be a believer of how this works because you'll feel the fulcrum and it works really easily. Can it, one person? Well, you got to come up. Oh, he beat you to it. All right, come on up, and I'll show this to you. You won't have to spend much time. All right, so Hugh, I gotta introduce myself. We do this. All right, so you're dislocated over here, right? Okay. All I'm going to do is put my elbow right here in the antecubital fossa. You and I will become close and interlock our fingers, and I'm gonna flex you. Do you feel the fulcrum?
Oh, yeah.
Yeah, and I didn't even get that far. Okay, you can let go now. Okay, all right, you can go back to your seat. Thank you. But if he can feel it, it's going to slide that olecranon right back into position. Works great, no strength needed whatsoever. With all the tools you need, you brought to work with you, even if you forgot your stethoscope. So that works really great. All right, posterior hip dislocations. One that's a little more complicated that works, I think we need to get away from, depending on how we dress for the day. You know, jumping up on a bed and yanking on legs doesn't make sense to try and get the leverage we need. It just doesn't look good. If you fall off the bed and you have 2 patients, you're one of them. One thing you can do is the one I've outlined here. If you are on the affected side of the patient and you're parallel with them, you can put that affected leg with the knee bent at 90 degrees over your shoulder. You put it right over here. Lower the bed so that you can stand up, and that's going to be your leverage. You don't need any arm strength. You have somebody stabilize the pelvis, you hold onto the thigh, and all you need to do is raise up and work internal versus external rotation. Common mistake that's made with hip dislocations. People think, I need to externally rotate it to get it out. When you externally rotate the thigh and the distal femur, what you're doing is forcing the femoral head behind the acetabulum. You're never getting it out. You need to internally rotate it first and disengage it so it comes out this way. That's how you'll get it to reduce. Internal rotation, and then stand up and try and work it that way. If you need to work it back and forth a little bit, do that. That works. What I like better is this Captain Morgan technique that's right up here. You can do the same thing, but turn sideways the patient, okay, sideways on their affected side, and all you do is put that popliteal fossa for the patient over your knee and use the ankle as the fulcrum for leverage, and have somebody stabilize the pelvis. If you don't have somebody stabilize the pelvis, when you stand up with the former technique, the patient just moves up and down. If you use Captain Morgan, it's really cool. People like it. You do this, and the patient moves up here. That is not what you want. You have to make sure the pelvis is stabilized. Those work really well. All right, now shoulders are very testable. Lots of different things we can do. Scapular manipulation works really well, but you always have to rotate the scapula externally to reaccommodate the humeral head and the glenoid fossa and bring it back. I used to do this all the time. I've gone away from it because I never really could tell, because there wasn't a great articulation. I didn't know for sure if they were back in. And if you sedated them, you say, hey, are you back in? They didn't care anymore. You didn't know. And so it was a little challenging, and I found a couple things that are better. We can use traction, counter traction. Don't choose this on the examination. There are degloving injuries and other things that happen with this, so be careful. Stimson technique, you can just hang some weights when they're in a prone position and come back later. I don't think any of us have the attention for that. We want immediate gratification. You come back later, yeah, you sedated me, and you're hanging my arm down, and yeah, I think it's back in place. Coker maneuver, I'll talk about this a little bit. Don't choose it. This is a high leverage maneuver. It uses external rotation and then lifting this all the way up and then pushing the elbow inward and then laying the arm over the side. High complication rate. High complication rate, don't do it. But external rotation in and of itself, just taking that portion of it, will give you, by some people's assessments, 85% success rate, just the external rotation component. And once you get to the point where you feel resistance, that's where the Coker people said, now we're going to go upward with this thing and jam this thing into place. What the external rotation people say is, get the patient to relax and go just a little beyond it. You might want to move it up a little bit if you can, bring the elbow in a little, but don't use a high leverage maneuver. The best one I've seen, and it completely revolutionized my practice about 3 years ago now, is the Cunningham technique. Do you know what this is? It's not Richie Cunningham. It's better. It's better than that. I will tell you, and this is the absolute truth, in the last 3 years since I tried this the very first time, I have never used sedation again for a shoulder, and I have not, I've been able to get people home in about 45 minutes with their shoulder dislocation. It has revolutionized the way I do this. There's a YouTube video you can watch. It's really good, but when you watch it, you'll say, it can't be that easy. There's no way that person probably wasn't dislocated. But I can tell you what they do, but I'd rather show you. Is there somebody, you and I go way back, but if there's someone else who'd like to come up, I will show everybody how to do this. And I swear to you, within 30 seconds, you will have this thing in, and you can get the patient home pretty quickly, and no sedation. Anybody? Somebody? Oh, he's coming up. Hugh, are you okay with this? I'm just asking. Just want to make sure. I care about you. Hey, Dean, how are you? So here's what we're going to do. So if you're dislocated here, what's crazy, what they talk about in the literature about this is you have to win their trust. You have to let them know. We have to have eye contact, and believe me, it's be a little uncomfortable for a minute, but if you can relax, this will be in 30 seconds. So if you can give me a chance for 30 seconds and try and relax a little bit, it's going to go into place. So what I do is I put my hand right over their proximal forearm. To enable to push downward traction on this, they have to hold somewhere here or here, but they've got to be there. I'm keeping downward traction, and this is all they say to do. Oh, you missed the eye contact. Look longingly into my eyes. It's already working, isn't it? Yeah. And as you rub, you kind of rub or massage the trapezius. If that doesn't work in a short period of time in the video, they get bored of it and they move to the deltoid. That doesn't work. They say that you can go to the biceps. If that doesn't work, I have no idea where you go from there, but you're taking one for the team. But they haven't talked about it in the videos or anywhere else. I've never gotten past the deltoid before this thing goes back into place. I think what happens is the minute they feel the massage, I swear thank you very much. They take a deep breath and they relax. I see it. It's like, oh, everybody likes a massage, a free massage too. Oh, they relax and boom, it goes back into place. And I swear to you it works. It is just that easy. But you have to get them to relax. If they're like fighting all over the place, you might as well not even do it. But if they will do it, it'll work great. So give it a try and let me know if it works for you. All right, this is to give you an example of, okay, the external rotation component, and then if you start moving up this way, that is the high leverage Coker maneuver. Central venous access, complications. You know the complications. They're greater with a subclavian approach than an IG approach, but you should probably go with the approach that is most comfortable for you. On the exam, they're going to want you to go with ultrasound guidance. Remember the femoral anatomy, so lateral to medial, nerve, artery, vein, ligament. Trauma considerations, place the line on the side of the trauma or the pneumothorax. They already have a pneumothorax. You don't have to be so careful with your technique. You can't create a second pneumothorax on the same side, at least not one that anyone will know about. So you can just slap that line in. You got it in pretty quickly. You got a vascular injury on one side, don't go there because you don't want to further injure that. And just remember that there's a contraindication for coagulopathy, particularly with the subclavian. You can't compress it. Umbilical lines. The big thing here is 2 arteries and 1 vein. When you look at it, you're like, yeah, I can do this. It goes out to 7 days postpartum. You clip off the end and you can do it, and you're like, oh my God, which ones do I go into? It's the one that doesn't look like the others. The 2 arteries, you don't want an art line. You can do that. You don't want an art line. So the one that looks floppier and less muscular and it doesn't look like the other ones, that's the vein. You advance 1 to 2 centimeters past the point where you withdraw blood and you secure it. That's all you need to do. Intraosseous, they will test you on this. I can almost guarantee it. It's rapid temporary vascular access, and PALS has said for years now, since this round of revisions and the one prior to that, it's not 3 IV attempts or 90 seconds, and then you move to this. You can be doing it on a parallel path, whoever gets it first, okay? So you can jump in. And anterior tibia is preferred in pediatric patients, but if they're moving this way a little bit for peds also, but for adults, I definitely go proximal humerus. You can still go the tibial site there, distal tibia. You can even go proximal tibia. I've converted my practice. I use these a fair amount of time to get good access. They're safe, they're quick, and if you just feel, this is not hard, you feel the greater tuberosity, this is not a complicated instruction. If you can feel it on somebody, you drill into it. You're done. It's very simple. Look at the complications. Infection, subcutaneous infiltration, hematoma, growth plate injuries, osteomyelitis. But they are very uncommon. There are a couple of compartment syndromes out there from a lot of fluid that was delivered. I'll give you one pearl right now on how to avoid this. If you're using the EZ-IO, I have no personal or individual interest in this at all, except I like the device, and no one else has anything out there. This works really great. This is not a threaded device, though. It spins quickly and goes through the skin like it was butter. Patients don't really seem to have a lot of pain. You don't seem to need local anesthetic. You can, once you get it in, you want to just infiltrate a couple cc's of 2% lidocaine and then flush, and that will make them feel better when you infuse. But what I want to make sure you're aware of, and I think this is where some of the complications with inadvertent infusions come from, look at the 5 millimeter line. If you've never used this before, respect the 5 millimeter line. What that means is, if you make a little hole in the skin, or you kind of push this toward the bone and you haven't opened up the skin, you want to get a sense that the 5 millimeter line is still exposed before you drill into the bone. Because if it's already under the skin, or it's going to be under the skin, what's going to happen is when you drill in and you put force, it will go into the bone and it'll go into the marrow. You'll be in the right place, but the skin will be inverted and there will be pressure. Since this is not a threaded device, over time, the skin is going to do this and come back up to baseline. And what's going to happen to that needle? You just lost your 5 millimeters that you needed to be in this position and still have it in the marrow. So respect the 5 millimeter line. This is actually a 15-month-old pediatric patient who was Amish that had sepsis and pneumonia, RSI through this site. And just so you know, too, any medicine that can be delivered in an IV can be delivered in an IO. And if you use proximal humerus, they've estimated 5 liters per hour can be delivered versus 1 to 2 in the proximal tibia. So you can actually give more fluid as well. All right, chest tube thoracostomy. You know all the complications. I won't go through them, but you need to be familiar with them. The big one I want to mention to you is this concept called the intrathoracic abdomen. The intrathoracic abdomen is interesting. That goes from the 4th intercostal space anteriorly to the 7th posteriorly, and that's the superior portion of the intrathoracic abdomen, down to the inferior costal margins. In that range of space is where the diaphragm moves when we breathe. Your best way of avoiding an intra-abdominal placement of a chest tube, thinking you have a massive hemothorax where you've actually placed it in the liver, the way to avoid that is have someone take a deep breath, or if they're being mechanically ventilated, give them a positive pressure ventilation at that time to expand the chest, move the diaphragm down. If they pull the diaphragm down, then the intrathoracic abdomen is further down, okay, and you can avoid it. And so very, very important. Pericardiocentesis. If they give you the option of jumping in there and using an EKG electrode, go ahead and do it. If you see a blip, then you know you've touched the myocardium. I don't think you necessarily need to do this. Here are the complications. How you do it is go to the left side of the xiphoid, 45 degrees to the ipsilateral shoulder. You're aspirating. You're going to get blood. You will get blood. So you're either going to get blood because you have a pericardial effusion, and it's hemopericardium, or you're going to go into most likely the right ventricle. How do you know where you were at? The important thing is when the blood leaves the circulation, it becomes defibrinated, and it doesn't clot. So if the blood clots, it wasn't a hemopericardium. If it's non-clotting, it was the real deal. And if it's an acute tamponade, 10 milliliters is all you need to restore hemodynamics to those patients. All right, ED thoracotomy. There's a couple things you need to be aware of. It is much better for preventing arrest than for treating it. And CPR less than 15 minutes, particularly when they have electrical activity, gives you a more likely chance of saving somebody. Poor prognostic signs, non-intubated field arrest greater than 5 minutes, intubated field arrest but greater than 10, and if their initial rhythm is agonal or asystole, it's really not helpful. And in the exam, don't use it for abdominal, just chest trauma, and blunt, okay? And so just make sure that you use this also. Predominantly penetrating, but if they ask you blunt, depending on how they ask it, you might go that direction. If you have no other options, particularly if they give you an image first, and you think that there may be an obvious bleed or some other problem, you go with it. The other thing that's in the ATLS manual is this, that they say, and this is a change for them, that pericardiocentesis is a temporizing measure for tamponade. They want a thoracotomy done. That's what the ATLS manual says. If you can just do it, do it. So that's why, if you know you have it and it's blunt, you could go that way. But this is predominantly going to be focused on the penetrating thoracic injuries. Okay, so the goals of the procedure, we're trying to control hemorrhage, open cardiac massage, cross-clamp the aorta. When you're cross-clamping the aorta, what do you want to think about? Where is it? You have two muscular tubular structures. One is the aorta, the other one is a feeding tube called the esophagus. Okay, early on, the aorta is going to be anterior to the esophagus, and later on in distal, further in the mediastinum, it's going to reverse position. All right? So what you should do in your resuscitation, I think, is drop an NG tube. If you've done your thoracotomy, you cross-clamp the aorta, now pull the NG tube out. If it slides back and forth freely, you cross-clamp the aorta. If it doesn't move, all you've done is do a very, very invasive weight loss program for this patient. You've cross-clamped the esophagus. Okay. All right, ultrasound. I heard Billy mention it a bit. We have a video that was produced just for you by EM Sono, and you're the only people that have access to it. They will give you more than you need to know with image recognition and what should be on the examination, so you can do that. If you don't have the access, email us or Gail, and we can get that for you. Okay, procedural sedation. We'll run through this. Preparation is key. Maybe MPO guidelines, they probably won't test you because a lot of people think they're not necessary. And know the adverse effects of all medicines that you're using, and continuous monitoring is key. ASA classifications are very testable. Not for clinical practice, of course, but for the examination. If you're an ASA 3, somebody with severe systemic disease and functional limitations, I take an aerosol, a couple times a day. It's not life-threatening every day, but I take a nitro once a week when I'm mowing the lawn. Okay, you have functional limitations. A 4 is, it's a constant threat to life. Anything beyond a 2, they want you to consult anesthesia. So for the test, if it's beyond a 2, so they have, severe systemic disease, they want anesthesia involved. Okay? Here's the equipment you need, including capnography and a monitor. MPO guidelines, you can review them to have them in the back of your mind, but I don't think they'll test you on them. Medications, we'll run through these quickly. So opioids. Opioids and benzos, when you use them together, there was an LLSA article that was published that says, give a lot of the opioids first, even max out on them before you add the benzos, what they want to do. Morphine, is it great? No. It's poor lipid solubility, so it's not great from that standpoint. We want it to get to the brain, and the brain is a lipid organ. There's a lot of histamine release that causes bronchospasm and hypotension. Liver metabolites, 4 times more potent and longer acting, so you can have some complications without the therapeutic benefit. Fentanyl, low complication rate. There is no histamine release. Great agent, but very short acting. And you can get this chest wall rigidity phenomena. And I've talked to some people who've seen it. I haven't. If you give it, they can get this chest wall rigidity thing. The only antidote may be succinylcholine. Narcan won't work. I've heard some people tell me they're preparing to intubate and it abated quickly and they didn't have to. But if you sense that the patient has that, you just move toward mechanical ventilation. All right, Brevitol or methotrexate, twice as potent as thiopental. So you have to be very careful with this barbiturate, okay? Duration is 10 minutes. So if you want to do a shoulder with this or a hip with this, make sure somebody's ready to do a modified jaw thrust because these people are probably going to go out. If you're not familiar with this medication, I wouldn't use it. It's a direct myocardial depressant and vasodilator. Versed, they would test you on this and you want to be careful. When you give Versed as an anxiolytic by itself, it's a pretty safe drug. When you start adding it to additional drugs, it has an entirely different safety profile, and so do the drugs you're adding it to. Not as safe. So high lipid solubility. If you combine it with alcohol and opioids, lots of things can happen that are not positive. Administer it in small doses and titrate it is the right way to go. And the Broslow issue. So what they say is, you look at all the literature on this, they say really it's lipid soluble. So if you have a big kid or a big person, you need to give more. more toward the ideal or more toward the actual body weight as opposed to the ideal body weight. But the problem is, you give a big dose up front, the brain gets more of it first preferentially before it gets distributed to all the other lipid tissue. So if you are going to give more than an ideal body weight based dose, watch them closely for respiratory depression and hypotension. Okay, propofol. We all know this. It's a great drug. You can't have any egg allergies. The protein is lecithin, that if they have that allergy, that's what would be an issue for them. It almost always causes hypotension, but it's almost always transient, and you don't even necessarily have to treat it. If they were 160 over 100 and now they're 140 over 80, who cares? But it will drop their pressure. If you're going to use it ongoing, like for sedation, for mechanical ventilation in the ICU, you need a dedicated line. It's high risk for infection. And one of the LSA articles, whether we believe it or not, and I question this, but it said it's less likely to cause respiratory depression than etomidate. And just keep that in mind. If that exact question comes up, you will assume that propofol will cause less respiratory depression than etomidate. Okay, etomidate, the only thing I'll mention here is it has no negative hemodynamic effects. It can cause some myoclonus. Adrenal suppression, they might talk about it. All the literature seems to be pretty clear that one dose has never killed anyone, and it does drop cortisol levels, but not below a normal level, and it's probably not significant. So don't worry about that. If the question comes up, you can give it. Ketamine, great drug. Positive inotrope also. Don't worry about it with increased intracranial pressure. It's not a concern. It can cause bronchorrhea, can cause a little laryngospasm. If they have the laryngospasm, don't get in there and instrument it. Don't look at it. That will make it worse. Just give them a modified jaw thrust and watch them, and they'll do just fine. It's a dissociative anesthetic, and usually patients will go in the mindset that they will come out in the mindset they went in under. So if they're kicking and screaming, they're going to come out kicking and screaming. If the lights are down and you're being comforting and they go in with a nice, gentle sedation, they're going to come out that way too. What's great about ketamine, Al Sacchetti talks about this a lot too, it gives us entertainment. Because this is a dissociative anesthetic, they will dream like crazy. And you can give them suggestions. And I started doing this after Al and I had a conversation about it, and it is a lot of fun. So what do you want to be when you grow up? This kid told me about a year ago, I want to be a soccer player. Well, okay, you're playing soccer now. What position do you play? He said, well, I play defense. I said, all right, so when you get the medicine, I want you to go play professional soccer. You're going to be the best defender in the world. He wakes up and said, what'd you do? I played soccer. I said, were you the best defender in the world? He said, no, I scored 6 goals. So don't waste this drug if you're going to use it. All right, reversal agents, Narcan. The duration of action is the same as fentanyl. Use something longer acting like morphine, you're going to have to be worried about resedation. Flumazenil or Romazicon, same duration of action as Versed. You use Valium for something, be careful, you can have resedation. And the biggie here is don't use Romazicon as an empiric treatment for overdoses. If someone has benzo dependence and you reverse it, they're going to have a severe withdrawal like seizures and status epilepticus. Here's a table that shows all the properties for you to review later. And now we're going to talk about administration for about 12 or 15 minutes, okay? So hang in there with me. Now these recent concepts have come out of LLSA articles, then probably the next 5 slides. So external quality metrics and regulatory bodies. So the Joint Commission and Healthcare Facilities Accreditation Program, which is actually from the American Osteopathic Association, and DNV Healthcare, a couple others, but these are the 3 big ones, have been given authority by CMS to accredit hospitals. They're just hospital accrediting organizations. That's all they do. But CMS, the Centers for Medicare and Medicaid Services, is a regulatory body. And it's our third-party payer as well, the primary one in the U.S. Okay? All right. So quality metrics for the physicians. You've got to know the names of these things. You want to know the nuts and bolts of these programs. Physicians' quality and compensation is going to be based on physician quality reporting system, and now the value-based modifier or value-based payment modifier is going into effect to implement the PQRS data that we've generated since 2007 to show that we're providing good quality and we're going to be compensated based on that. And I'll show you a table in a moment that'll show you how that's going to work, if any of us can figure it out. On the hospital side, there are really 3 different programs. There's OPPS, Outpatient Prospective Payment Program. The OQR means Outpatient Quality Reporting. There's Inpatient Quality Reporting and an Inpatient Prospective Payment System. The hospitals have to report on 100% of those items, so they get a 2% reduction in Medicare fees. So it's big for them. They have to report on all of them. We get to select a handful. And they are compensated based on the value-based purchasing program that came out in the last few years. Interesting fact that you may or may not want to know, anyone hear the HCAP surveys, the patient satisfaction surveys? 30% of the hospital's score and compensation under value-based purchasing, 30% is based on that HCAP score. Okay. All right, so here's what the value-based modifier is looking like. There are 5 basic areas in quality of care for the composite score. One of them is patient experience of care. But what's really scary is there's another huge component that's a cost composite score. So how efficient are you? We don't know how they're going to calculate this yet. But if you are less efficient and these quality components are not as good with the metrics that are accepted and designed, you're going to get paid less for the same work. On the other hand, you can get paid the same or maybe even a little bit more if your quality is better and your utilization is less. Hospital crowding and diversion. This is an article from Peter Viccellio that was an LSA article. If you put people in the hallway upstairs instead of in the hallway in the emergency department, what happens? The mortality rates are higher for standard admissions than hallway admissions. Hallway admission patients don't get sicker because you put them in a hallway upstairs. Matter of fact, what happens is they get to a bed quicker because of the nurse's station. They oftentimes look at them and they have a place to put them. They'll get the bed ready and they'll move them in there quicker. That's been documented. That's a fact. Rates of subsequent ICU admission are actually higher for the standard admission people, not for the hallway admission. So if you're laying in a hallway upstairs, people would think, oh, they're going to get worse care. They're going to get sicker and go to the ICU more often. That's not true either. Those are 2 testable concepts. This LLSA article talked about communication and what is associated with patient safety in the emergency department. I'm not going to insult you by reading them, but these are the factors that were identified in this LLSA article that impacted patient safety. Just be familiar with them. They're kind of general and they're kind of common sense related. Medical errors. So we're talking about imaging and patients' understanding of risks of imaging. So did they have confidence in the medical care provided if they got imaging versus not? They had a 0 to 100-point scale. If patients in this particular study didn't get any imaging, they rated their confidence of the care they got at a 20. If they got imaging, it jumped to a 90. So I think what it tells us is imaging is important unless we explain to them why the imaging doesn't help us make a better decision. And you can explain that in a way that shows maybe you're smarter than the images. Or I have back pain. Why don't I need an x-ray? Because I don't think you've broken anything, you don't think you've broken anything, and the x-rays aren't going to show us anything that's going to change the way we're going to take care of you. They understand that. And then you throw in, and besides, we'd be exposing you to ionizing radiation. And they're like, well, I don't want any of that. I don't know what that is, but I don't want any of that. So then they don't want the x-ray too. They have also noted that 70% underestimated the radiation dose of a CT versus a chest x-ray, and there was a poor understanding of cancer risk. So patients don't understand this concept. All right, quickly we'll talk about disaster medicine. There's always at least one question on disaster medicine. What is it? A disaster is when the destructive effects of natural or man-made forces overwhelm the ability of a given area or community to meet the demand for health care. It can be external. Things occur outside. Train crash, plane crash, multiple cars. Internal, because the hospital is overwhelmed. You can have a fire, power failure. All of this sounds like an average day in most of our EDs. Everything's a disaster. Okay. All right, so this is a testable item too. You have to really think about this. I don't know if they'll ask you this, but I will tell you behind the list for remembering from a disaster standpoint. Phases of disaster management: planning and preparedness, mitigation, response, recovery, and evaluation. This changed and evolved in the last couple of years. That's why I think it's very testable. And the important factors for a response to be successful: you want an established EMS system, correct assessment of the extent of the disaster, and you want to mobilize the resources you need. So we'll talk briefly about federal agencies. There's not one federal agency that really is overseeing the whole national trauma system, but FEMA really provides federal aid, which is important. 27 federal agencies are involved, state agencies as well, the Red Cross. And here's the take-home and testable point if they test you here. It must be requested by the governor. No one else can request it, and it can only be authorized by the President of the United States. That's easy to remember, and it's easily testable. National Disaster Medical System, this is for largely domestic disasters to provide additional medical support, and the people that respond are the DMAT teams, Disaster Medical Assistance Teams, medical volunteers. This is important to remember. Communication is the first problem encountered in disasters. It's the first, but a lack of backup resources is the most common. Communication is the first, lack of backup resources is the most common. And the hospital has to have a plan for the Joint Commission, and you have to have 2 drills per year. That could be a question. How many drills are you required to have for disasters under the Joint Commission requirements? It is 2. Here are the key functions they want you to have in your plan, and they want those tested with your drills, and they want specific plans in place for media coverage. Where do they go, and who's designated to deal with the media? Incident command system, standardized EMS command and control and organized response, management of multi-agency and multi-jurisdictional response. That's what incident command is about. I don't think you'll get tested on it, but you should be aware of it. Triage tags, don't think the concert will have them, but the qualifying exam probably will. You spend your time on the red tag people. That's the key. Someone who has a black tag may mean they could be dead. Of course, you're not going to try and assist them, but they may be dead but don't know it yet. So if they have non-survivable injuries, you don't spend resources there. You stick with the reds and then go to the yellows and the greens. All right, medical legal aspects of emergency medicine. And there will be at least a couple questions here, I can guarantee you. So EMTALA. What is the purpose of EMTALA? It was to make sure that people weren't sent to other facilities because of a lack of ability to pay. And it was a good idea, but it certainly had some consequences for us that aren't so positive. So you didn't dump patients on another hospital because of a lack of ability to pay is one reason they call it the anti-dumping law. The other reason is because we have gotten so many additional patients in the ED responding to this unfunded mandate, you can't even take 5 minutes in your shift to take a dump. Anti-dumping law for sure. You're experiencing it too. We'll move on. Okay. Medical screening examination. This is important. Anyone presents not just to the ED, but to the hospital with an emergency medical condition, they are afforded under EMTALA a medical screening examination, which includes stabilization. It's not just, wow, you look pretty sick, you've been screened. That includes stabilization. The campus rule. Very important. Came from Ravenswood event that happened in Chicago when it was in the evening. There was, I think it was a multiple stab wound or multiple gunshot wound patient just down the street. And they were looking, the staff was like, I'm not going down there, it's dangerous. Well, you go get him. Well, I'll go get him. The guy ended up dying, so they came up with the campus rule. And the campus rule says it's basically all of your buildings in a 250-yard radius and anything else that we think is your campus when we look at your campus. And you have to have a response. The ED doesn't have to go get the patient necessarily, but you have to have an organized response because they have an emergency medical condition. Okay. And scope and extent of the medical screening examination is just based on the chief complaint and what they have and what they need, and the resources your hospital has. If you have no resources, you can't stabilize them too much, you're going to send them quicker. A good example is if you're a level 3 trauma center, a patient has a liver lac and they're a little bit unstable, stabilization might include packing the liver and sending them to the level 1 trauma center to complete their care. That's still part of the medical screening examination. All right, who can do it? EMTALA says a qualified medical provider. Qualified medical personnel just have to be outlined in the bylaws. Doesn't have to be a physician, but it has to be in the bylaws. Very important. This federal transfer law applies to hospitals receiving Medicare dollars, and there are on-call physician responsibilities. I'll clear up a couple things. The transferring hospital has to and gets to determine the mode of transportation, and there is no EMTALA requirement for an on-call provider to see someone the next day. You know, we've always thought that. Will you see the hand surgeon tomorrow? You call them, yeah, we'll see him. And then they get turned away because they want a $1,200 copayment up front. They're not obligated under EMTALA to see them the next day. That's not part of EMTALA. Okay, so transfer requirements, you've got to have, the benefits outweighing the risks, informed consent. You need facility-to-facility communication. It does not say anywhere in the EMTALA document that it has to be physician to physician. The facilities have to agree. And violations will not be covered under a professional liability policy like your medical malpractice policy, so be careful. HIPAA. We'll talk just a couple minutes about HIPAA. It's important. I think there'll be a question on this. Health Insurance Portability and Accountability Act. There are several components, but the biggest and the thing they would test you on is protected health information and making sure you protect that information with patient confidentiality. Civil and monetary penalties exist. There are criminal penalties that exist. I think the first case that I recall, and I don't know if there's been one since, I think it was at UCLA, I think in 2010, there was a cardiothoracic surgeon from China that was working as a research assistant at UCLA, wasn't performing well, got fired, and accessed over 300 records of coworkers and the stars and VIPs, and went to prison for 4 months and had fines. So this can be serious stuff. So the privacy rule is established to protect protected health information and to make sure the patients have control over where this goes. And they don't want it going places that it shouldn't. And so this is a good thing. All right, a lot of people think, HIPAA is frustrating. HIPAA even did away with the concept that you have to get consent from another hospital to get other records. If they've consented for treatment, they've consented to transfer records for continuity of care, for billing and quality assurance. So if they were at another hospital yesterday, you can just get the records. No one seems to believe that. No other hospital will send you the records without the consent form, but HIPAA did away with that. It was helpful. So basically, the key point here is if you learned about this information through your job, it's protected health information, and anything that can result in identifying the patient is considered a key identifier and would need to be de-identified. Quick story, we're running out of time, but there was an emergency physician in Rhode Island a few years ago that had a great trauma case, posted a Facebook post, but provided so much detail that people in the community figured out who the person was, and it was a HIPAA violation. And that person was sanctioned by the state medical board in Rhode Island. It was an innocent thing, but it was unauthorized disclosure of protected health information. If someone consents to treatment like we talked about, they're consenting to normal transmission of paperwork for the things we talked about. But if there's something else you want to do, oh, I want to publish this, or somebody comes in and says, I have a subpoena, I want these records, there has to be oftentimes another authorization filled out. You just have to make sure it follows the guidelines. That's more for you to be aware of, so you're not caught off guard. I don't think you'll get tested on that. All right, child abuse. Mandatory reporting in all states. There's legal immunity for you if you report, so you should have a high index of suspicion and a low threshold for reporting. Admission is recommended if you really are suspicious of this, and multiple injuries in various stages of healing are pathognomonic for it. And sometimes it can be subtle, commonly seen with delays in treatment or frequent visits with vague complaints. They keep coming back. Why? You don't have anything. They're crying out for help, and so consider that a possibility. The most likely are going to be less than age 5, but particularly less than 18 months. Long bone fractures are really concerning for this, particularly posterior rib, the most common in infants. Metaphyseal fractures, bilateral, multiple, and again, various stages of healing. The ones that aren't really likely to be as commonly found in abuse are going to be linear skull fractures, clavicular skull fractures, and long bone greater than 5. After you get past 5, you kind of get into some trouble and you create some trauma. Consider a CT of the brain. If we found a kid with a subdural, we would do the skeletal series. So if we find a fracture suspicious of abuse, then why aren't we doing the CT to check the brain? We need to do that too. Medical decision-making capacity. This New England Journal of Medicine article was an LSA article talking about medical decision-making capacity, and it's the patient's ability to make decisions. If they are oriented to person, place, time, and situation, and understand the risks and benefits of what you want to do, they get all that, they can refuse treatment. There's been this discussion that if you force somebody to get treatment and they say they don't want it, you can be arrested for assault and battery. Do you know how many cases have ever been tried with those charges against a healthcare provider? Anyone know? 0. There are a lot of reasons for this, but when you're trying to take care of somebody and do the best job for them, you're going to get a lot of deference on that. We won't go into some of the other details of why an attorney would never take a case from somebody who is spitting at healthcare providers and punching them and doing those sort of things. They're not going to take those cases. They're not good clients, and so it doesn't happen. Competence is an area you could be tested on. We don't determine competence. That's determined by a court, a judge, as the agent of the court. We can determine medical decision-making capacity, but not competence. Okay? Civil commitment, just being psychotic, is not a reason to be committed. You have to be a risk to yourself or others or gravely disabled. Strongest predictor, also from that New England Journal of Medicine article, is a lack of insight is the strongest predictor that you're not really making rational decisions and you might need commitment. Informed consent, we touched a little on it. You have to be oriented to person, place, time, situation. You have to pose the benefits and the risks of the proposed treatment to them, including no treatment at all, and let them make their decision. You've got to explain all of that. Okay, implied consent. If it's emergency implied consent, hey, I can't ask you if you want a central line placed, you're in cardiac arrest. It's the right thing to do. You just document why you needed to do this under an emergency condition, and that's fine. Okay. Minors. Well, consent should be obtained when possible from the guardian when they're under 18. This changes a little bit from state to state, and there shouldn't be any delay in care, however, for 2 reasons. We'll come up with I'll discuss the second one in a minute, which is more important. The first one is everyone's going to understand if you're trying to take care of them, they're going to decompensate, you need to treat them. But call the parents or guardians at the same time you're trying to treat them. You can do this on a dual mechanism and document all your efforts. Emancipated minors. So if people are basically married or pregnant, active military duty, they're living away from home, they've got receipts, electric bill or something like that, or their condition is a public health hazard, you can treat them as emancipated minors in most states. Again, those vary by jurisdiction a little bit. And here's an important take-home message. There's this thing called preemption. Preemption means when the federal government decides to legislate in an area, state governments cannot. The state statute or the federal statute must be dealt with first before you even consider the state statute. Consent to treatment is a state statute, okay? It's not federal. So when you're dealing with EMTALA and the medical screening examination, technically speaking, if you were to not do the medical screening examination and wait for consent, that's an EMTALA violation because you need to fulfill EMTALA first before you ever deal with the state statute, which is consent. So you need to do the medical screening examination. You're fine. So if someone approaches you and says, wait, we can't, we got to get a hold of the parents first. No, EMTALA says we have to do this, but please keep trying to get a hold of the parents, and that's the way you should do it. If you're really trying to act reasonably and do the right thing for the patient, no one, no judge, no jury, no layperson is going to question your behavior. They really aren't. But withholding treatment is going to get you into trouble. Advanced directives, remember, applies to acute cardiac or respiratory arrest. Almost every DNR says in the event of a cardiac or respiratory arrest. It doesn't say if you are about to have a cardiac or respiratory arrest. So you still treat them, okay? Unless they have an advanced directive that says, but I don't ever want to be intubated. Otherwise, you would. And when in doubt, resuscitate. This won't be on the test, I don't think, but you need to be aware of it. PULSed is a new concept coming out. Physician orders for life-sustaining treatment. They actually have orders that are updated, signed, even notarized, that say this is actually what I want done in detail. Better than a DNR or another advanced directive. Patient restraints is a team approach. You might need it because the patient is just behaviorally out of control, or it's medically necessary. They're going to pull out their endotracheal tube, whatever it is. You've got to give them close observation, chemical before physical, document the reason, physician order has to be there, and reevaluation. I believe it was the Lake Hospital system near Cleveland many years ago in the 90s where they restrained a patient face down, fluffed the pillows to make him comfortable. They came back when they assessed him, and he had a respiratory arrest. That's an issue. So that's why all of these requirements are in place. When you have the sticker or the order, you have to fill out the reason, the time. It's because of that case. Okay, duty of the third party. We're almost done here. A named third party. If somebody comes in and says, I am going to kill that person, then that's a named third party. You have an obligation to inform the police. The unnamed third party is, wow, you just had, over the course of 6 hours, 5 dilaudid in the emergency department. You really shouldn't drive. So you should tell the patient, you shouldn't drive. You don't necessarily have to tackle them, but you've told them, you had a seizure, you shouldn't drive. You are protecting the unnamed third party, and that includes STDs as well. Until this clears up, you really shouldn't have any contact with people. Treatment of partners of STD patients, be very careful. Can I just get a prescription for my significant other? Actually, why don't you give me 6? That could happen. You haven't evaluated those patients. Don't do that. If they have an adverse reaction to the medication or something, you have no medical record, you've never assessed them, don't do it. Have them send them in. If they're willing to come in, make sure they do that. All right, so mandatory reporting by healthcare providers varies by jurisdiction, but usually communicable diseases and violent acts need to be reported. So on the exam, it would be very, very general that way. Disclosure of medical error, another LSA article by Gallagher, really good stuff. And we're moving to the direction that we're going to start informing people on the front end. They found in this article, this is what people wanted. They want to be informed ASAP there's been an error. You need to express regret for the error. We're sorry this happened. It shouldn't have happened. Just so you know, we didn't want it to happen. We feel bad about it. Advise them of the follow-up that will occur. Most patients, when you look at the data on this, want to know what's not going to happen to anyone else. Tell me how you fixed it. That's what they want. And then demonstrate the plan for avoidance. Let them know. So it needs to be done in a structured way. Good Samaritan laws. No duty to act. You don't have any duty to help this person, but you do anyway. That's different than somebody saying, hey, can you look at my ankle? I just twisted it. Well, yeah, come on over. You just accepted that. You now have a duty. You might be acting nicely. You may not be accepting payment, but that establishes a duty. So this protects non-compensated providers without a duty. You can't apply this to ED cases. There has been a case recently tried, too, where somebody went upstairs to address a code, and there was no bill filed. No one believed that you were a good Samaritan because you were in the ED and you went to the ICU to take care of a patient. That doesn't fly either. All right, malpractice terms, duty to treat. Do you have a duty? If you're in the hospital, they come for care, you have a duty. Standard of care is what a reasonable provider would do under similar circumstances with similar training. And if you breach that duty, that's when you can be determined negligent. Direct cause and proximate cause will come back in just a minute. Damages. You can provide horrible care, but if there's no damage to the patient, there's no case. You need these elements for a lawsuit, or you can't even file it, okay? So there have to be damages. Now, your alleged negligence has to be the direct and proximate cause of the damages. So the direct cause is, if you did something and it was negligent and it hurt the patient, that's the direct cause. But proximate cause is, did somebody else's negligence intervene to break the chain of responsibility? And a lot of people don't understand that. I'll give you a quick scenario, and I think we've got a couple slides after that. Quick scenario here. All right, so if you were working in the ED, you saw a 70-year-old lady with abdominal pain, you were worried about AAA, you gave her some fluids, you did some labs, we were fine, you gave her some pain medicine, it's almost completely resolved, she feels a lot better. Radiology report comes back and says, CT's negative except for some diverticular disease, and you send her home. She comes back on your shift, dead. And postmortem examination shows a ruptured AAA. Well, you sent her home. That's going to be the alleged negligent act. You should not have sent her home. And do you think you were negligent in sending that person home? Maybe, maybe not. That's what will be debated. What comes out, though, is that the radiologist misinterpreted the CT and she had a leaking AAA on that CT but didn't report it to you. Now you can say you have a proximate cause defense. Well, yeah, I sent her home, but for that happening, or but for the information of the CT, I mean, I would have kept her, would have done something different. It was their negligence that prompted me to be negligent. Therefore, my negligence is not the proximate cause of this patient's damages. Does that make sense? Does that clear that up a little bit? Okay, good. If not, we're moving on anyway, okay? We've got to. All right, so professional negligence, we talked about it. Contributory negligence is an older term and comparative that really doesn't apply to, people ask this, so I put it in here. It doesn't really apply to medical tort liability. It really doesn't. So if it's contributory, if you even had 1% contribution to what happened to you, you don't get anything. And that's kind of an older term. Most jurisdictions don't use it. And I know medical providers say, well, you had a problem, you had a pneumothorax, and we didn't treat it right, but it's because you were a smoker, so it's your fault. You know, it's not a responsibility. Nah, it doesn't work that way. Comparative negligence is, well, if you were 35% responsible, then you can get 65% from the defendants if they were negligent. Joint and several liability is the deep pocket rule, so you can apportion degrees of responsibility and negligence to multiple defendants. But the key is, in those jurisdictions that use it, the plaintiff is always allowed to get 100% of the verdict, whatever it is, of the judgment or settlement. So if it's $1 million and you apportion it to these other providers, what's interesting is you can be the person who only had 1% fault assigned to you, but if for some reason all the other providers are gone, they're either dead or they don't have any money or they were settled with them, but the judgment was for $1 million, you had 1%, the patient still is entitled to the $1 million, and you are the last one standing, you will pay. Okay, so common reasons for medical malpractice: failure to diagnose, complications from treatment and procedures, delays in definitive management. Most frequent, missed fractures and dislocations of wound care and foreign bodies and missed tendons. Expensive claims are cardiovascular and neurological all day. Really bad stuff. I am all set. I'll be outside. I'll be happy to take your questions and enjoy your break. Thanks, everybody, and good luck on your test.